There is a measurement taken in under 10 seconds requiring no equipment beyond a flat stretch of ground that predicts how long you will live more accurately than your blood pressure, your cholesterol, or your smoking history. It does not require a blood draw, a questionnaire, or any medical training to administer. It takes less time than tying your shoe, and the number it produces correlates with all-cause mortality more strongly by modern metric ever measured by modern epidemiology. The test is called the one-legged standing balance, and the people who can't hold it for 10 seconds are, on average, twice as likely to die within the next decade as those who can. The study came from a team led by Claudio Gil Araujo at the Clinimex Exercise Medicine Clinic in Rio de Janeiro, published in the British Journal of Sports Medicine in 2022. They took 172 participants aged 5'1" to 7'5" and asked them to stand on one leg, barefoot, hands at their sides, eyes open, for 10 seconds. That was the entire test. No treadmill, no electrodes, no blood panel, just one leg, 10 seconds, a stopwatch. Over the next 7 years, 123 of those participants died, after controlling for age, sex, body mass index, and pre-existing conditions. The people who could not perform the balance test had a hazard ratio of 1.84 for all-cause mortality, an 84% increase in risk. The grip strength test, the walking speed test, the chair stand test, none of them predicted death as powerfully as this single second measure. I want you to think about what that means. The ability to stand on one leg for 10 seconds is not a test of muscle mass. It is not a test of cardiovascular fitness. It is a test of something far more ancient and far more fragile, the system that keeps you upright against gravity without you thinking none about it. Your body does not consciously balance. If it did, you would fall over the moment you tried to talk or look at your phone while standing. Balance is run by a coalition of 3 systems operate apparatus in your ear, the vestibular apparatus in your inner ear, the proprioceptive sensors embedded in your muscles and joints, and the visual system. All 3 feed into the cerebellum, which integrates the data and sends corrective motor commands faster than you can perceive. The one-legged balance test is a stress test for this entire network. When it fails, it means something in that chain has degraded. The degradation is measurable in the vestibular system years before symptoms appear. The semicircular canals and otolith organs in your inner ear contain hair cells that bend in response to head movement and gravity. These hair cells do not regenerate. You are born with roughly 30 of them in each ear, and every decade you lose a fraction. By age 50, the average person has lost about 40% of the vestibular hair cells in the superior vestibular nerve. The loss is silent because the brain compensates. It rely more on vision, more on proprioception until one day the compensation runs out. The one-legged standing test detects that moment of compensation failure. And the reason it predicts mortality is that the same degenerative processes attacking the vestibular system are also attacking the cardiovascular system, the nervous system, the nervous system, and the metabolic machinery. The balance test is not the cause. It is the early warning signal. There is a second mechanism operating at the same time, one that connects balance directly to direction with brain health in a way that reverses the conventional direction of causality. It is not just that a failing body produces poor balance. Poor balance itself may accelerate brain decline through a pathway involving the hippocampus and spatial navigation. The hippocampus, the brain structure most associated with memory formation, is also the brain structure responsible for spatial mapping and self-motion tracking. Every time you stand and walk, your hippocampus is firing place cells and grid cells that encode your position in space. When you stand on one leg, that spatial computation is stressed. The brain must integrate vestibular, proprioceptive, and visual data to maintain a stable internal map of where your body is relative to gravity. If that integration is poor, the hippocampus receives degraded input. The degradation of spatial input to the hippocampus has been directly linked to hippocampal atrophy. A 2008 study from researchers at University College London led by Sarah Naomi James followed 4,809 older adults for 10 years and found that slower gait speed and poorer balance were associated with steeper rates of hippocampal volume loss. The hippocampus shrinks when it's not used for its primary function, navigation through physical space. And one of the most potent stimulants for hippocampal neurogenesis, the growth of new genesis, that requires the integration of vestibular and proprioceptive data. Standing on one leg is a concentrated dose of that signal. The people who cannot do it are not just revealing existing damage. They are failing to deliver the sensory stimulus that keeps the hippocampus alive. Here is the part of this story that I find poignant. The one-legged standing balance test is not a diagnosis. It does not tell you why you are at higher risk. It only tells you that you are. But it also tells you something else, that the system can be trained. Balance is not fixed. The vestibular system cannot regenerate its hair cells. But the brain's ability to integrate the remaining signals can be dramatically improved through practice. A 2E fine randomized controlled from research at the University of Jena in Germany, led by Kathleen Gord, showed that 12 weeks of balance training in older adults improved standing time on one leg by an average of 4.9 one leg by an average of 4.9%. The training consisted of 3 sessions per week, each lasting 30 minutes, using progressive and some more difficult stances, feet together, tandem stance, single leg stance with eyes closed. The gains persisted at a 6-month follow-up. The mechanism of this improvement is not in the ear, is in the cerebellum and the sensory cortex. Balance ranging induces neuroplastic changes in the cerebellar vermis, the region that processes vestibular input, and in the primary somatosensory cortex, which integrates proprioceptive signals from the joints and muscles. The brain learns to extract more information from the same degraded peripheral sensors. It becomes more efficient at weighting the relative contribute vision, the remaining vestibular vision, proprioception, and the remaining vestibular signal. The physical hardware of the inner ear does not change, but the software that interprets it becomes more sophisticated. This is the difference between having a damaged microphone and having a better audio processor. The microphone still captures less signal, but the processor extracts meaning from the noise more effectively. The practical implication is that the one-legged balance test is not a death sentence. It is a diagnostic signal that triggers an intervention. If you can't hold the stance for 10 seconds, you can train it and recover it. The same study from Araujo's group showed that the participants who failed the test at baseline but improved their balance over the follow-up period, had mortality rates that converged toward those of the past group. The risk was not fixed. It was modifiable through the very mechanism that revealed it. Now let me take you deeper into what balance actually is at the level of physics and biology, because the 10-second test only scratches the surface. Your body is an inverted pendulum. The center of mass sits roughly at the level of the second sacral vertebra, about 5% of your height above the ground. The base of support, when standing on one leg, is a rectangle roughly the size of your foot. The pendulum is inherently unstable. Without active correction, it would fall in under 1 second. The fact that you can hold it for 10 seconds or 30 seconds or indefinitely is a triumph of real-time feedback control. The correction signals travel from vestibular nerve to the vestibular nuclei in the brainstem, then to the cerebellum, then down the vestibulospinal tract to the antegun trunk, to the anti-gravity muscles of the leg and trunk. The entire loop takes about 1 milliseconds. You are making roughly 10 corrections per second, every second, without any conscious effort. The muscles doing the work are the tibialis anterior on the front of the shin, the peroneals on the outside of the ankle, the gluteus medius on the side of the hip, and the quadratus lumborum in the lower back. They fire in a coordinate sequence that has been practiced since you took your first steps as a toddler. The pattern is stored in the cerebellum as a motor program. When you stand on one leg, you are not learning a new skill. You are accessing a program that has been running continuously, in the background, for your entire life, and you are asking it to operate at the edge of its capacity. The shaking you feel in your ankle after a few seconds is not weakness. It is the motor units recruiting at maximum frequency, the way an engine vibrates at redline. The reason the balance test is so predictive is that it captures degradation that is systemic. The vestibular hair cells are among the most metabolically active cells in the body. They require a constant supply of oxygen and glucose delivered through the labyrinthine artery, a branch of the anterior-inferior cerebellar artery. When cardiovascular health declines, the labyrinthine artery is often the first vessel to show reduced flow. The hair cells begin to die, but the same reduced flow also affects the hippocampus, the prefrontal cortex, and the myocardium. The balance test is a window into the health of the entire microvascular system. It tells you that the small vessels are failing before the large vessels do. And the loss of balance is not just a signal of vascular decline. It is also a signal of neuromuscular decline. The muscle spindles in the leg, the Golgi tendon organs at the muscle-tendon junctions, and the cutaneous mechanoreceptors in the sole of the foot all degrade with age. The density of Pacinian corpuscles in the plantar skin decreases by about 30% between ages 20 and 70. The foot becomes less sensitive to pressure and shear. The brain receives a degraded signal about where the foot is relative to the ground. The motor corrections become slower and less precise. The pendulum begins to oscillate more widely. And then one day, the oscillation exceeds the base of support and you fall. The fall is the event. But the loss of balance is the process that precedes it by years. And the one-legged standing test detects that process while it is still subclinical, while the person still feels steady walking on flat ground. The test is not measuring whether you will fall tomorrow. It is measuring whether the system that prevents falling has already begun to fail. And that failure predicts everything else. Because the same mechanisms that keep you upright are the mechanisms that keep your brain oxygenated, your vessels patent, and your nervous system intact. Now I want you to think about the foot itself, because the foot is not a passive platform. It is a sensory organ with more mechanoreceptors per square centimeter than your fingertip. The sole of your foot contains about 2 nerve endings. Pacinian corpuscles that detect vibration, Meissner's corpuscles that detect light touch, Merkel cells that detect pressure, and Ruffini endings that detect skin stretch. When you stand on one leg, every one of these receptors is firing information about the distribution of your weight across the metatarsal heads and the heel. The brain is using that data to compute the position of the center of pressure in real time and to adjust the motility in the leg and trunk to keep that center of pressure within the boundaries of foot. The margin for error is astonishingly small. The center of pressure during single leg stance moves with an area roughly the size of a quarter. If it drifts beyond that area for more than about 3 odd milliseconds, the corrective response is too late and the foot must step down to prevent a fall. The people who pass the 10-second test are maintaining that quarter-sized zone of stability for the entire duration. The people who fail are letting the center of pressure wander beyond the boundaries, and they either put the other foot down or they fall. The difference between passing and failing is not strength. It is the fidelity of the sensory feed loop from the foot to the brain and back to the muscles. A 2010 study from researchers at the University of Michigan, led by Susan Len, Whitney, showed the one-legged stance tests had significant higher thresholds for vibration in the plantarfalling detection in the plantar surface of the foot. They could not feel the subtle shifts in pressure that the brain needs to maintain balance. The sensory signal was there, but it was too weak for the brain to use effectively. And this sensory degradation is not just a consequence of age. It is accelerated by conditions that damage peripheral nerves: diabetes, vitamin B12 deficiency, chronic alcohol use, chemotherapy. The one-legged balance test is sensitive to all of them. And here is where the story changes, because balance is not only a physical phenomenon, it is a cognitive one. The cerebellum, which coordinates the motor corrections, is connected to the prefrontal cortex through the cerebello-thalamo-cortical loop. When you stand on one leg, the prefrontal cortex is not silent. It is allocating attentional resource to the balance task, suppressing irrelevant sensory input, and monitoring the error signals coming from the cerebellum. This is why balance degrades when you are tired, when you are stressed, or when you are doing a second cognitive task simultaneously. The dual task cost of balance is measurable. A 2006 study from researchers at the University of Waterloo, led by Kara Patterson, showed that forming a verbal fluency test while on one leg reduced balance time by an average of 2% in healthy young adults. The brain cannot maximize both tasks at once because they compete for the same prefrontal resources. The implication is profound. The one-legged balance test is not just a test of your vestibular and proprioceptive systems. It is a test of your brain's ability to allocate attention under load. When that allocation fails, it signals that the prefrontal cortex is already compromised either by age, by reduced blood flow, by accumulated amyloid burden, or by the early stage of neurodegenerative disease. The balance test predicts cognitive decline years before memory symptoms appear. A 2019 study from research at the Mayo Clinic in Rochester, Minnesota, led by Rodolfo Savica, followed 145 cognitively normal older adults for an average of 2 years. Those with poor baseline balance had a 15-fold higher risk of developing mild cognitive impairment or dementia during the follow-up period. The association held after adjusting for age, sex, education, and cardiovascular risk factors. The mechanism is bidirectional. Poor balance predicts cognitive decline, and cognitive decline worsens balance. The prefrontal Sonson regions, shown of the first brain regions to show reduced mental activity in early Alzheimer's disease. As it declines, the attentional resource available for balance shrink. The corrective responses become slower and less accurate, and the fall risk increases. The fall then leads to head trauma, which accelerates the neurodegenerative process. It is a feedback loop that feeds on itself. The one-legged balance test detects the entry point into that loop, while it is still possible to interrupt it. And the interruption is possible. The evidence for this is not theoretical. A 2021 systematic review and meta-analysis published in the British Journal of Sports Medicine, led by Yves J. Squin from the University of Basel, analyzed 29 randomized controlled trials of balance training in older adults. The pooled effect showed a 37% reduction in fall risk, and the improvement in single-leg stance time averaged 4.3 seconds across all studies. The training protocols varied, but the common element was progressive challenge, standing on one leg, with eyes open, then eyes closed, then on a foam surface, then while performing a secondary cognitive task. Each level of difficulty forces the brain to adapt, to build new neural pathways, to extract more information from the same degraded sensors. The most effective protocol in the literature came from its 2018 study at the University of Sydney, led by Catherine Sherrington, one of the leading researchers in fall prevention. The protocol was simple. Participants performed 4 balance exercises: single leg stance, tandem stance, heel-to, toe walking, and lateral step-ups. Each exercise was held for 30 seconds every 3 or repeated for 3 seconds. The total time investment was 20 minutes per week. After 6 weeks, the intervention group improved single leg stance time by 57% compared to controls. 12 minutes per week. That is less time than it takes to watch a single episode of a television show. And the improvement was not just in balance. The participants also showed measurable improvements in gait speed, in chair stand time, and in self-reported confidence in their ability to walk without falling. Think about what that means for the scale of the intervention. The one-legged balance test identified people at an 84% higher risk of death within 7 years. A 12-minute per week training protocol, applied for 16 weeks, can move a significant portion of those people from the fail group to the pass group. The risk is not a fixed property of the individual. It is a modifiable state, and the modification does not require expensive equipment, pharmaceutical intervention, or medical supervision. It requires a floor, a wall for support, and the willingness to stand on one leg for 30 seconds at a time. The barrier to entry is not cost. It is knowledge. And now you have the knowledge. Now the evidence calibration. Because the 5 mechanisms described here sit at different levels of certainty. The association between poor single-leg stance and all-cause mortality is robust, replicated across multiple large cohort studies in Brazil, Japan, the United Kingdom, and the United States. The hazard ratio of 1.84 from Arao's study is consistent with the findings from the UK Biobank, where a 2023 analysis of over 1,000 participants showed a similar effect size. The connection between balance and hippocampal volume is supported by the UCL study and by a 2020 neuroimaging study with the Universaling Curie from the University of California, San Francisco, which showed that poorer balance correlated with reduced chordal thickness in the medial temporal lobe. The mechanistic link between vestibular degeneration and microvascular disease is anatomically well established, though the direct causal chain from hair cell loss to mortality has not been proven in a randomized trial. The bidirectional relationship between balance and cognition is supported by longitudinal data, but the precise molecular pathway, whether amyloid, tau, or vascular pathology is the primary driver, remains an active area of investigation. What is not ambiguous is the intervention. The Cochrane Review on Fall Prevention, updated in 2023, rates balance training as one of the strongest evidence-based interventions for reducing fall risk in community of 1 done, 1 done, with a number needed to treat of 1 ton. That means for every 1 people who complete a structured balance program, 1 fall-related injury is prevented. This is comparable to the number needed to treat for statin therapy in second-day prevention of cardiovascular events. The evidence for balance training is as strong as the evidence for cholesterol-lowering medication in people who have already had a heart attack. And yet balance training is not prescribed, it is not screened for, it is not discussed in annual physicals. The one-legged standing test takes 10 seconds, requires no equipment, it predicts mortality more powerfully than blood pressure, cholesterol, or smoking history, and is almost never performed in clinical practice. The gap between what the evidence says and what medicine does is not a conspiracy. It is a structural failure of a system that is optimized for diagnosing and treating disease, not for detecting and preventing functional decline. The one-leg balance test does not fit into any existing specialty. It is not cardiology, not neurology, not orthopedics, not geriatrics. It is a cross-disciplinary signal that belongs to no department and therefore to no one. But it belongs to you. You can do it right now. Stand up, find a wall or a counter if you need it for safety. But try to do it unsupported. Lift 1 foot off the ground just a few inches. Start the timer in your head. 10 seconds. If you can hold it, you are in the pass group. If you cannot, or if you wobble significantly, or if you need to put your foot down before the 10 seconds are up, you are in the fail group. And that information is not a diagnosis. It's a signal. It tells you that the system that keeps you upright needs attention. It tells you that the vestibular input, the proprioceptive feedback, the cerebellar integration, and the prefrontal entral allocation are not operating at their optimal passenger in capacity. And it tells you that you can change that. The intervention is simple enough that you can begin it in the next 60 seconds. Stand on one leg for 30 seconds. Switch to the other leg for 30 seconds. Do that 3 times per leg. That is 3 minutes. Do it again tomorrow. Do it every day. After 2 weeks, try it with your eyes closed. After a month, try it on a folded towel. After 2 months, try it while counting backward from 100 by 7s. Each layer of difficulty forces the brain to adapt, to build new connections, to extract more signal from the same hardware. The hardware cannot regenerate, but the software can improve. The cerebellum can learn. The prefrontal cortex can allocate attention more efficiently. The sensory cortex can amplify the weak signals coming from the foot. The system is plastic. It responds to demand. The one-legged standing balance test is not a parlor trick. It is not a fitness challenge for social media. It is a biologic signal that has been hiding in plain sight. It costs nothing. It takes 10 seconds. It tells you something about your future that no blood test and no imaging scan can tell you with the same predictive power. And the response to that signal is a 3-minute daily practice that costs nothing and requires nothing but your willingness to stand on one leg. The ancient machinery that keeps you upright against gravity is waiting for you to demand more of it. It is still there. It is still trainable. It is still capable of rewiring itself in response to the simplest possible challenge. One leg 10 seconds every day. The signal is there. The response is up to you. The ancient machinery that keeps you upright against gravity is waiting for you to demand more of it. It is still there. It is still trainable. It is still capable of rewiring itself in response to the simplest possible challenge. One leg, the singular day. The signal is there. The response is up to you.